Hello, and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConell from Victoria University in Australia. The idea behind Inside Exercise is to bring to you the absolute who's who of exercise research. So, exercise physiology, exercise metabolism, and exercise and health. And what I'm really wanting is for you to get your exercise information from the research experts rather than from influencers. And indeed, today I bring to you Associate Professor Lykke Sylow from the University of Copenhagen in Denmark. She's an expert on exercise and metabolism. So she's done a lot of studies looking at metabolism in normal, healthy situations. And then more recently, she's branched out to look at exercise and metabolism in cancer. So we talked about the really remarkable effects of exercise in regards to cancer. So not only does exercise reduce the likelihood of getting cancer, it also improves the prognosis in those that have cancer. In addition to this, it makes it less likely that you will get cancer again. And remarkably, she talked about how there's evidence that exercise can actually reduce the likelihood of the cancer metastasizing. So the primary cancer spreading to other parts of the body. There's evidence that exercise can reduce this. And also we know with cancer, depending on the cancer, you can get a reduction in your insulin sensitivity. So what happens is the tumor takes up a lot of glucose, and it actually has a situation where the body becomes less able to take up glucose. So we call that insulin resistance. The cancer takes up glucose, the body takes up less glucose, and it may even be feeding the glucose to the cancer. So that's really quite interesting. And then you also have cancer cachexia, which is a loss of body weight with cancer. And there's evidence that a lot of that loss of body weight is muscle. And as Lykke talks about, it may well be one of the benefits of exercise is that you maintain or reduce the rate of muscle mass loss, and therefore reduce the rate of frailty with cancer, and therefore that can help with your prognosis. I found it really interesting. I think you will too, so stick around. Now, if you'd like to do me a favor and also help get the word out about Inside Exercise, if you could please like, comment, subscribe, etc. This will make it more likely when people search something to do with exercise that Inside Exercise will be recommended to them. Now, as usual, it's best if you watch or listen to the whole podcast to get the full context. But if you'd like to jump around a little bit, you can look down in the notes and see that there are timestamps. So if you're on YouTube, you can click on the time and it'll take you to that point. Or on the other platforms, you can just look at the time and move yourself to that point. Okay, so enjoy the chat with Lykke Sylow. Hi, Lykke. How are you? Welcome to Inside Exercise. How are you doing?
Hi, Glenn. Thank you for having me. I'm good. How are you?
Yeah, I'm good. It's great. It's funny to see you actually in this capacity because I've managed to have, as you know, 3 6-month sabbaticals in your area of the neck of the
Yes, I
woods
know.
and love it there. And now I'm going to see you in this capacity. And
Yeah,
thank
it's
you for
been
agreeing. It took me a while. I did actually say, come on, let's do this for a while, but it's good to have you on here.
yeah. Sorry it took me so long, but now I'm ready. I'm looking forward to
No,
it.
no, 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 no. It was more me wanting to have you on is the point. I'm not saying you should have come on earlier. It's more that I've been keen to have you on. You're an up and coming star. So the first time I went to Copenhagen in 2013, you were a PhD student. And then you've just gone from strength to strength. I was actually checking to see if you're actually a professor yet. You're on the professor program. Is that right? But you're an
Yeah,
associate
yeah.
professor.
I'm not a professor yet.
How
No.
does that work? You have a professor program or something there?
Yeah, there is at the University of Copenhagen. They have these professor promotion programs that I'm
Hmm.
on, but how it works, to be honest, I'm not exactly sure.
Sounds kind of promising then, isn't it? If you're on that
Yeah, well,
program.
I hope, of course, one day.
Mhm. All right. So we're going to be talking about cancer. This is the second podcast about cancer. And obviously it's a very emotional, I think everyone's been touched by
Mhm.
cancer. And it's a hard one. And it's obviously might be triggering for people that could be people listening that have cancer at the moment
Mm.
or have survived cancer or have family members that have cancer or are trying to avoid cancer. I think all of us think about cancer or have been touched by it. So yeah, it's a tricky one, but it's very important. And people aren't always necessarily going to be wanting to, it's not the first thing people think of, oh, I should go and exercise, or to say to their family member, you should go and exercise. But so I think it's a bit of a different one, but it's very important. And it is the second time we've had a podcast with exercise and cancer. So the first one was Kathryn Schmitz. So I really encourage people to have a look at that one. And then I guess the focus might be a bit different today. So you've done a lot of research on the effect of cancer on body weight, muscle mass, metabolism, etc. Yeah. So do you want to just give a bit of a background, and also how did you actually end up being a researcher in this area?
Yeah, I can just start with a bit of like brief background of the topic because it is an interesting topic, and the majority of research so far has really focused on beating the cancer. And that has really produced enormous leaps in our ability to treat cancer. But what we lack now is a better understanding of what is actually happening in the entire body when people are affected by cancer, because this creates real life issues for patients, that their bodies are being affected, not only by the cancer, but also by the toxicities of the anti-cancer treatments. And these are really important for survival because emerging evidence really suggests that this dysregulated metabolic control and muscle wasting are associated with poor survival for patients with cancer. So I really look forward to talk more about how exercise can help these things because this is what the work we do in my lab.
Yes. So,
Then,
oh, sorry.
yeah,
So
then
you're
you,
saying that the actual so people know that people tend to lose weight, they've got cancer, and with that muscle mass, etc., and there's
yeah.
metabolic effects. But I guess they don't necessarily realize that's you know, associated with earlier death, and that the exercise can attenuate that, so therefore prolong life in that way. Is that right?
I don't know what people know, but
Yes,
it
fair
is
enough.
really becoming evident that it is the wasting of muscle mass that can be detrimental to survival for patients with cancer. And a building amount of evidence now shows that exercise could be very important in preventing that detrimental effect of the cancer.
Yep. Okay. So how about we just talk? I know the main focus won't be on, be some of these sort of mechanistic changes, but what is the evidence? Because it's kind of easy sometimes to think exercise improves everything, and I actually think it does. But I don't know if it improves my rate of tooth decay or something. But generally exercise improves everything, and you tend to think, okay, exercise is going to reduce the chance of getting cancer, improve the prognosis if you get cancer. But what is the actual evidence? And what are we talking about? Are we talking about 5%, 10% sort of
Yeah.
reduction improvements, or is it
Yeah,
more? Yeah.
it's a good question. And I mean, the evidence is very strong for that exercise lowers the risk of getting cancer. We know this, and this is one of the most very important endpoints that have been described here, is how the risks for getting cancer are lowered if you live an active life. And this has been evidenced in meta-analysis, which are really sort of the gold standard for scientific evidence that we have, because it compiles many different studies and showing the direction of all of these studies. And that really shows that exercise or active living protects against cancer. And that is up to 13 different types of cancer.
Okay.
So this evidence is very good. Then there's also strong evidence that if you're an active individual, so if you meet the recommended guidelines for exercise, then if you get cancer, you also have improved survival rates. And I do want to say that all cancers are not the same. So cancer, we talk about cancer, but cancer are really like 100 different diseases. And it's also been shown that the effect of exercise depends on what cancer type it is. So for some cancers, there is like an enormous protection from death if you exercise. Whereas other cancers, the effects are a little lower. But
Okay.
but the evidence is strong for these things. Then there's also emerging evidence that even for people who did not exercise coming into their cancer diagnosis, if they pick up exercise afterwards, that this could also have some protections both on survival, but especially on the cancer-related fatigue, and also on the problems that comes with chemotherapy treatment. But we can get more into this later, I
Wow.
think.
Okay.
Yeah.
Now, I think you've touched on an important thing, that there's so many different types of cancers. So it's probably hard to sort of pin it down, because I was sort of going, okay, if we go back to the first part you said of reducing the chances of getting cancer, are we talking about, how much are we talking about? But again, it probably depends on the cancer. Yeah. So,
Yeah.
are you able to say something like, oh, you're 20% less likely to get cancer in the next 10 years, or are you 30? Do you know, are we at that point yet, or?
Yeah, it depends what cancers. For some cancers, there is a lowered risk of about 50%. So this is really
Wow,
substantial amount of
50%.
lowering.
Mm.
And I mean, some of the obesity-related cancers, the risk of death and also risk of cancer recurrence if you're physically active,
Mm-hmm.
the percentage is also lowered by 50% or sometimes even more. And then there are other cancers like lung cancers where there is a protection of getting cancer. There is also protection of death from cancer, but the percentages are quite a bit lower. But it's so difficult to say. And the reason I'm not super keen on these percentages is that every cancer patient is so different.
Mm.
And these are based on millions of people who will have exercised differently. They will have eaten differently.
Mm-hmm.
So I think it's very difficult
Environment.
to set
Mm-hmm.
a point. But these meta-analyses, they do show quite a substantial reduction in the risk of getting cancer. And it is actually so that if you're a non-smoker,
Yep.
physical inactivity is the largest risk factor for getting cancer. So
Wow.
it's substantial, yeah.
Okay, so why don't we just drive that home again? So if you're a non-smoker,
Mm.
so is it only really smokers
Inactivity.
that have that the biggest risk is smoking, basically? But if you're a non-smoker,
Mm.
the biggest risk is physical inactivity.
Yes.
Wow. So above diet, etc. Because there's often a focus on, oh, the stuff we're getting in the diet is it's more preservatives and more, this and that, and
Yeah.
ultra, refined foods and all the pollution, but the inactivity is the biggest.
Yes, it is. Together with obesity. Yeah.
Okay.
Yeah.
And I guess they tend to go hand in hand anyway. So if you're more active, and does that get difficult to tease out? So if the person's more active, they're going to tend to not be as obese. But is that
Yeah.
independent of obesity as well?
Yes. And that is an issue with these big trials, including a lot of people, is that we often don't have information about this. So these data are based on people who choose to be physically active or people who have chosen not to be physically active for many reasons.
Mm-hmm.
And the people who live an active lifestyle, they usually have many other things that comes with it. They might eat a better diet. They might also have a lesser risk of obesity. They may have a stronger social support system. They may have a
Mm-hmm.
higher income and so on, better access to healthcare. So there are many different confounding factors sort of that comes along with the healthy lifestyle
Mm-hmm.
that are really difficult to tease out in these big meta-analysis. But even if it is teased out, you can sometimes correct, for example, for socioeconomic status. You can sometimes correct for body weight if you have the data. The effects of activity is still there on the risk of cancer, at least.
Right. All right. And I guess we're getting there with the metabolic side. So you touched on, obesity, etc. So you think cancer. So just to give a bit of background, it's become sort of apparent in the last 10 years or so, I think, that people with type 2 diabetes or insulin resistance, which is a precursor to diabetes, tend to have more cancer.
Mm-hmm.
And people with cancer, do they tend to have more, they become insulin resistant. So maybe why don't you explain that a little bit, the metabolic sort of side of this?
Yeah. Yes, I mean, you mean what are the metabolic effects of cancer? And I mean, there are many metabolic abnormalities associated with cancer. And as you mentioned, they're also not unlike those that we normally associate with type 2 diabetes and obesity. Um, and again, cancer is not just one disease. So the metabolic effects, they will manifest differently depending on the cancer type. But one thing that looks like is common for most cancers is that they are associated with dysregulated glucose metabolism.
Mm.
And we know that cancer cells take up a lot of glucose. So we know that tumors, they really consume a lot of glucose. But what we're starting to realize now is also that while the tumor takes up a lot of glucose, the peripheral tissues of the body, the muscle and the adipose tissue, likely begin to take up less.
Mm.
And that is due to what you mentioned, that patients with cancer are often insulin resistant. And this has been reported in many different types of cancer, although I will say that we still need more evidence of this. But we recently tried to compile all of the evidence of whether or not patients with cancer are insulin resistant and not. And that was in a meta-analysis we did, and that really clearly pointed towards that people with cancer had insulin resistance. And they had insulin resistance even to the level of what is seen in people with type 2 diabetes, so quite substantial insulin resistance. So I think this is an important factor for some cancers at least. And another metabolic effect is the development of cancer cachexia. So cancer cachexia is this rapid development of tissue wasting. It's really visual in the people who have it because it comes with a quite fast reduction in body mass that is due to reduction in muscle mass and in fat mass. And this is called cancer cachexia. And that occurs in some, but not all cancers. And that is due to dysregulated protein metabolism.
Okay. So how about we just make sure we don't lose a few people here. So we'll just, if you don't mind, I'll just explain insulin resistance a little bit to people. So if you have a meal, you assuming there's carbohydrate in the meal, this glucose, it gets absorbed in the blood. The pancreas then releases insulin, and that insulin then tells the tissues, you mentioned the muscle, but also the muscle's the main site, but also fat and the liver, to take up that glucose, and then the glucose levels come down again. But what can happen is you become what's called insulin resistant. So the insulin's released, so glucose goes in the blood, the insulin's released, but as it sounds like the tissues are resistant to it, so they don't respond to it. And if anything, you have to release more and more insulin to get the same response. And that's what we're talking about here. So it's very different. People think of people with diabetes, they need to inject insulin. That's more your type 1 person with type 1 diabetes. They don't have any insulin or not enough. The people with type 2 diabetes, if anything, they're releasing as much insulin or more, especially early on. They may have problems with the pancreas later. So you're saying that what's happening is that the tumor is taking up a whole bunch of glucose, but your own body, your normal body, the muscle, etc., is not taking up as much glucose. So you're becoming insulin resistant. But in the end, you may actually be taking up just as much glucose or even more. Is that right?
Yeah, maybe.
Because
We don't know this yet. Because the tumor will take up a lot of glucose, and it probably will, regardless of whether the peripheral tissues are insulin resistant or not. Because the reason that the muscle and the adipose tissue needs insulin to take up the glucose is because they do not at baseline have the pores that glucose needs to enter the muscle through at the plasma membrane. But the tumors have these pores there all of the time. So they don't require insulin. So regardless of insulin resistance, the tumors are just fine to take up the glucose. But the rest of the periphery needs insulin there, or at least they need to be able to respond to the insulin.
Yeah, so you're saying pores, P-O-R-E-S, in case people. So pores, the little holes to take up. So you're keeping it nice and simple, which is great. So the muscle has these transporters, and they basically are a pore that you bring in the glucose, and the insulin makes, you get more pores basically, or greater turnover. And you're saying the tumors don't actually need the pores, so they don't need the insulin. So
no,
they just take it up.
They need the pores still.
Yeah,
all cells need the pores because glucose is a water-soluble molecule, so it cannot cross any of the membranes we have because they're made up of lipids. So the tumors also need the pores there, but their pores are just there all of the time. Whereas in the muscle and the fat, the pores goes inside the cell and only goes to the periphery when insulin is there.
Perfect. All right. Now that's interesting. Now it makes me start wondering, I don't know if people know this or not, but do you think the person with cancer becomes insulin resistant partly because the cancer's trying to take up all this glucose and it releases something to make the body insulin resistant, like it's sort of taken over the body type of thing? Or is it more, because you're losing muscle? Some people anyway are losing muscle and there's not as much, muscle to take up the glucose. Do you know what I mean?
Yeah, I know what you mean. It's a bit difficult to answer because we don't have hard evidence, but we do have some evidence to support that the cancer can itself produce insulin resistance in the body.
Wow, okay.
And that evidence comes from mice, where if you for example, give a mouse lung cancer, you can then see that this mouse becomes insulin resistant, that less glucose goes into the muscle and the adipose tissue in response to insulin. So this we know because in humans it's extremely difficult to tease
Yes,
out
of course.
the effects of the tumor itself, or if some of the effects are due to the treatment, because of course we always treat our patients with cancer.
Yes.
But whether it's sort of, I mean, you ask if the tumor is on purpose making the body insulin resistant to secure
Mm.
its own nutrients,
Yeah,
right?
it just occurred to me. I don't know.
And
Yeah.
this is I think this is such an extremely important thing that we can only speculate about. But if we
Yeah.
speculate and go down that sort of rabbit hole, it would be an extremely powerful mechanism for the tumor
Mm.
to ensure nutrients are directed to the
Yeah.
tumors. Okay, because if you're a tumor, you rely on a very high turnover, they proliferate, they want to metastasize,
Mm.
and they need a lot of glucose. They also need a lot of insulin because insulin is actually a tumorigenic hormone. So in tumor cells,
Yeah.
insulin levels will increase proliferation of these tumor cells. We know this from culture cells. So if you're a tumor, from a tumor's point of view, you could induce insulin resistance in the periphery, ensure that you get the glucose and not the competing other tissues,
Exactly.
while at the same time, perhaps, it's still a thought experiment, but perhaps the body would always compensate if it's
More
insulin
insulin,
resistant by producing more insulin.
which would stimulate.
And that would
Yeah.
also be beneficial for the tumor because then it could grow more.
Yeah, exactly.
There is some evidence for this speculation in the literature. I think this is the case, but it still needs
Oh,
to
you
be
do?
backed by more evidence.
Oh,
Yeah.
good. Yeah, it just suddenly occurred to me. Or maybe it was from seeing some of your talks, because I know I've seen some of your talks when I was in Denmark
Mm.
with inducing tumors in mice and things. But anyway, the funny thing I also thought of while you were talking about it is almost like, I don't, sounds kind of bad because we're comparing a tumor to like a baby, and I'm not doing that. But when you're pregnant, you tend to become insulin resistant as well, so that the baby gets the glucose first. So I'm not trying to make any sort
Yeah,
of analogy there.
exactly.
Yeah,
Yeah, exactly. I've done that. It's not, I wouldn't call it a comparison because it's like
it's
no,
not
not a
at all.
comparison at
No,
all.
it's not.
But the way that it's similar is that there is this, um, you know, feature of the body that needs the energy to survive. And during pregnancy, that's a fetus. And it's a completely normal physiological reaction to pregnancy is that the peripheral tissues become insulin resistant. And that is a mechanism that is believed to make sure that all nutrients are directed to the growing fetus.
Exactly.
And sometimes that sort of turns into gestational diabetes. So you become too insulin resistant. And this is normally if you're also overweight during pregnancy or maybe inactive. But there are definitely physiological similarities to what is seen with these growing cancer cells. Yeah.
Exactly. Well, that's very interesting thought experiments there, and I wonder we'll have to see what comes with more research. Now, you mentioned cachexia, so why don't we just say what cachexia is again, and then we'll just talk through that. And I guess you mentioned that not everyone gets cachexia, so do we know, like what % of people get cachexia and what it is and all that sort of stuff? Yeah.
Yeah. Cachexia is really quite a complex condition that's most visibly manifested as this really rapid reduction in body weight. I think many of the listeners probably knows Steve Jobs as a founder of Apple, who got pancreatic cancer and sadly passed away only at an age of 56-year-old. And I think many of us could follow him on the media and see how rapid a weight loss that he was undergoing before he unfortunately passed away. And I think many of us can recall pictures in our heads or maybe even have loved ones who have had cancer who becomes extremely skinny very fast and who has no appetite, has no energy. And these are really the key manifestations of cachexia that are very visible. And it's an enormous problem in oncology because it is associated with very poor survival.
Okay.
But in the clinic, there's really defined 3 stages of cachexia. So the first one is pre-cachexia, and that is defined as a minor weight loss, so less than 5% weight loss that is not due to lifestyle modifications within a period of 6 months. And then there is cachexia, which is a weight loss of more than 5%. That's also not voluntary over this period of 6 months. So this is something that the oncologists will ask the patients about because they, of course, will not have waited the patients half a year before they got the cancer
Before.
diagnosis, but they will ask the patients this. And then there's refractory cachexia, which is really characterized by this irreversible, very rapid weight loss that is also accompanied by a life expectancy of less than 3 months.
No.
Yeah.
Okay.
And the cachexia can occur in people where you can see it very visibly. But it's really the loss of muscle mass that seems to be the process that is driving the adverse effects in cancer. Because you can also have an individual with a normal BMI or with an overweight BMI who gets cancer. And actually, obesity is a driver of cancer. So therefore, there are many people with cancer who are also overweight or obese. And here, cachexia, or at least the loss of muscle mass, can be quite disguised because it can occur even in the absence of any visible loss in body mass. And we know that even in patients with cancer who are also have overweight, also the loss of muscle mass that cannot be seen, even in the absence of any loss of body mass, is also detrimental to survival and is associated with a lower risk of surviving the cancer.
Oh, okay. So we just make sure we're clear on that, or I'm clear on that. So cachexia isn't necessarily loss of fat mass and muscle mass. You may actually be maintaining your mass but losing muscle. So you think that the muscle is the main thing here.
Yeah, so cancer cachexia is defined as loss of body mass. But the problem with cachexia is that it is due to a loss of muscle mass. And this loss of muscle mass you can also have even in people who are weight stable.
Okay, so they wouldn't be technically having cachexia, but they'd be having negative effects by losing muscle. And do you know what the mechanisms? Okay, so it depends on the cancer again, I guess, and how advanced it is. But people often, I assume, don't feel like eating as much. And so is it eating less, or is it the loss of? Is there a change in body of the metabolic rate? Like, do we know what's actually going on, or is it? I guess it's multifactorial as well.
Yeah, it is multifactorial, but we do have some ideas. And I also want to say that cachexia, so these high rates of weight loss, are mostly common in some cancers, whereas others are completely spared. So these are very common in people with pancreatic cancer, head and neck cancer, colorectal cancer, and lung cancer. Whereas, for example, patients who have breast cancer, they are often spared from this loss of muscle mass. But yeah, I think we're still disentangling the biological reasons for why cancer can cause the wasting of non-tumor tissues. I mean, one reason is really the food intake. It is an important factor because we know that lowering caloric intake can also cause the breakdown of muscle and fat. Unfortunately, in people with cancer, nutritional support do not increase their muscle mass.
Sorry, what was that, Ben? What did you say then?
So in patients with cancer, nutritional support
nutritionals.
Yep. Does not really suffice to increase the muscle mass of the patients. And it can only have minor effects on reversing the loss of body weight. So what needs to be served is really the muscles. And that is not obtained by increasing food intake. I mean, we all know this.
Yes.
We all know this from during Christmas, right?
Yeah.
When most of us take up enormous amount of calories. We don't become muscular. We don't become stronger. We don't gain more energy. We gain fat mass.
So we're getting towards exercise here.
Yes.
Yes.
And people with cancer, they do need to build muscle mass. They need that because this is what helps them go through their treatment. This is what is protective. This is where all the data is pointing. This is also the muscle mass that helps people uphold their quality of life by being able to do daily activities. So I think this is really where exercise could make a big difference. But we know the food intake is a major issue. And we're also right now, I think we're in one of the biggest experiments in the world about what happens with reductions in food intake with regards to weight loss. I mean, we have millions of people on Wegovy Ozempic to lose weight, and many of these people, they lose up to 16% of their body weight. And this is fantastic, I think. For a patient with cancer, this would be called cachexia.
Yeah,
But it has really taught us that limiting food intake can reduce fat mass. That's no surprise, but it really also lowers muscle mass. And with the emerging studies of Wegovy, shows that nearly half of the body weight that is lost on these weight-losing drugs is muscle mass. So that's quite a substantial amount. So definitely food intake plays a role for people with cachexia, but there's more to it. And we know this because, for example, with cachexia for patients with head and neck cancer, it's about 70% of the weight loss that is muscle mass. So much more substantial that would be expected from just lowering food intake. So I think there are many more things to it, and we are still disentangling these, I think. And we know that the tumor can secrete factors that can then travel in the blood and can potentially influence other tissues, such as, for example, the skeletal muscle, to cause muscle wasting. So this is also, I think, a potential for why cancer can produce this muscle wasting. And another component is the immune system. So the presence of the tumor is really recognized by the immune system, and that results in this chronic elevation of inflammation. And we know that inflammation can actually cause the breakdown of proteins within the muscle and the fat tissue. So I think this could also be a contributing factor to the process.
Back to this theory we had maybe about the tumors themselves trying to produce glucose, or taking up glucose. I wonder if what's going on there is, and this might be getting slightly nitty-gritty, but we know that if you are not eating much, you'll lose weight and you lose fat and muscle, as you said. And that's why we often say the best way to go on try and lose weight is just do exercise to try and maintain your muscle while you're losing fat. I wonder if what the tumor's doing there is almost preferentially breaking down muscle so that the amino acids from the muscle end up going to the liver and then getting converted to glucose. It's a process called gluconeogenesis. I wonder if that's actually partly what's going on. It's trying to kind of keep the organism, the person, producing glucose from muscle, from because if you're not eating much, you won't be taking in much glucose.
Yeah.
So where's the tumor going to get the glucose? So maybe it's by stimulating the muscle to break it down.
It could be. I think we need the evidence to show this. There is some animal models that have shown that the hepatic glucose output is increased in cachexia. But there are also some others that have shown that it's not. So I think the data still is not in agreement about whether or not this is the case. Yeah,
it's interesting. Yeah, I know. Okay. I keep thinking, oh, this is such a horrible topic. We're talking about, it's easy to get interested scientifically, and then you go, hang on, we're talking about cancer. It's really horrible. But okay, so some cancers you tend to have a lot of cachexia, and others you don't. Now okay, so why don't we talk about exercise? So so you're going to be losing, depending on the cancer, as you said, almost preferentially muscle. And actually, before that, I was thinking, so if you're really muscular before you get cancer, do you know, is that because you did say earlier that if you've been physically active and you exercise before you get cancer, you've got a better prognosis. I wonder if they've looked at it enough to see if it's people that were like weight trained before they got cancer versus, say, more endurance versus just doing lots of steps, more physically active. I wonder if people have done a breakdown on that. Is it sort of the absolute muscle mass? If you start off with all these big muscles.
Yeah,
which,
I'm not aware of any studies that have sort of broken down the training regimen as such coming into the cancer and then looked at either treatment toxicity or survival from cancer. But we do know that those that are more muscular and stronger coming into the cancer diagnosis, and this actually goes into any diagnosis you can get, any disease, the muscle strength is a very strong predictor of survival. So this is absolutely the case. But whether or not it's because of their exercise or the different training regimens, that has been associated with the high muscle mass.
Yeah, yeah.
That is more unclear.
I guess I was wondering if it's like, if you've got all this muscle mass to start with, I guess it will take longer to get down to that critically low sort of muscle. Do you think is it the amount of muscle that's lost, or you think it's getting so frail and getting, you know what I mean?
Yeah. I think there is definitely a limit, a lower limit to how much muscle and strength you can get. And that set point will just be higher if you're very muscular and very strong to begin with. So it will take maybe longer to reach the set point for when a person can no longer do different everyday tasks or begin to feel very frail and fatigued. To my knowledge, there is no evidence to suggest that, for example, cachexia influences young people less, because they usually have more muscle mass compared to old people, but old people normally is the ones who get cancer. So I think the way I read the literature is that cancer cachexia can set in to anyone. There really is no protection as such, but if you then exercise, then it is less likely to be as accelerated. I think that is where the data is pointing, but we still need a lot of randomized controlled trials to show this. But the set point is just higher.
Yes, to start with. You've got more muscle to start with. Okay, just wanting to bring together, so we talked about the sort of the metabolic side of it, how the tissues, the person becomes insulin resistant. And then we talked about the cancer cachexia. But are these things, do they overlap at all? So because I'm assuming when you lose muscle, you become less insulin sensitive, become more insulin resistant when you have less muscle to soak up that glucose. Are they thought to be sort of two separate processes, or are they sort of interacting?
Yeah, that's a little bit of a controversial views, I think. We know that the insulin resistance in response to cancer in animal models sets in before the cachexia. So if anything, the insulin resistance could contribute to the cachexia, but before it sets in earlier, it is a little more unlikely that the cachexia causes the insulin resistance, I think. We also know from some of the studies that have measured insulin sensitivity in patients with cancer. So they have done these hyperinsulinemic euglycemic clamp studies that you also know so well, which is really the gold standard for measuring insulin sensitivity in humans. And they have done this in weight-matched people. So people with cancer and weight-matched healthy controls. And here, it's a little difficult because they don't really show the individual data points for those people, the patients with cancer who have cachexia versus those who have not. But it doesn't look like cachexia or the presence of cachexia sort of is a driver of the insulin resistance at the moment. So the way I read the literature, it is insulin resistance that comes first. And then whether or not that can be a contributing factor to the development of cachexia, I think that is still unclear. But it's not unlikely, because insulin is a very important anabolic hormone. And we know this because if we look at people who got type 1 diabetes more than 100 years ago, when there was no insulin treatment, you would see that these became extremely skinny very, very fast. So there would be this huge acceleration of a loss of muscle mass because the insulin is such an important anabolic hormone. And if insulin doesn't work properly on the muscle, it could be that that insulin's effect on protein synthesis could be altered. So there is a rationale to believe that the insulin resistance comes first. This is also what the evidence show. And then there is sort of the biological rationale to that could contribute to cancer cachexia, but we still need the evidence to support that last bit. I think.
Yeah, I guess the fact that you're saying that all cancers people get insulin resistant, but not all cancers people get cachexia. So it sounds like there might be some dissociation there, but we're getting a bit nitty gritty. I can't help it.
I don't know if all patients with cancer becomes insulin resistant. I just know that the type of cancers we have looked at, where the hyperinsulinemic euglycemic clamp has been done, they show insulin resistance in these patients. But whether it applies to all cancer in all patients, I think that's really something that is important to determine in the future, because that would also sort of direct where to put in the efforts of treating this insulin
Ah,
resistance.
sorry, I thought I got it. I thought you said you did a meta-analysis and you saw
We
every
did, but that didn't
cancer.
include all cancers.
Okay.
Yeah.
It's
And
complicated.
it wasn't, it was, there's only 11 studies that have studied this. So we need, I mean, so this is the
It's very early.
representative section of some people with cancer, and we need more people included, I think, to be
Now, this
able
is
to.
probably a bit of a silly question, but I've never quite understood why the cancers are so different, and why the treatments even. So, I remember I used to review grants and they'd be saying, we want to look at this effect of this drug or whatever on colon cancer, and then another one effect of this drug on breast cancer. Okay, well, obviously breast there's going to be different with different sexes, but just say colon versus stomach or whatever. I'd always think, well, why wouldn't the same drug, if you take it systemically, why wouldn't it work, the same on all the cancers? I've never understood that. Is it, I think I just don't understand cancer enough, to be honest with you. That it's such a multifactorial thing. We sort of say cancer, but they're not that same. So you can't expect the same drug would have the same effects. Is that what I'm sort of trying to answer my own question? But anyway.
Yeah, I mean, I cannot answer the question either because I'm no oncologist or a cancer cell biologist. But there are some genetic mutations that are important for the development of cancer in certain tissues, because the cancer really originates from a normal tissue cell.
So
the cancer really originates from just a normal tissue.
Yeah. And then
right?
There's a mutation.
So for example, some of the immune therapy, they're very much specifically targeted towards lung cancer because many lung cancers are associated with a certain mutation.
Okay.
But I think you need to address this question with someone who knows a little more about this.
Yeah.
I think the effect of treatment is extremely interesting, also in this context of exercise and metabolism and muscle wasting, because one of the reasons that cancer cachexia is so detrimental to people who have cancer is that it actually lowers the tolerance for the treatment. So the most effective way to beat cancer is, of course, to get the treatment that is needed to beat the cancer. But in many cases of cancer cachexia, the tolerance for the treatment of the body is simply lower. So sometimes people get a certain treatment that is needed to beat the tumor, but sometimes this dose then needs to be lowered because the toxicity and the rest of the body is too high, or maybe even the treatment is discontinued. And this means that you cannot effectively beat the cancer. And this is often the case in people with cancer cachexia. And here there is, I think, strong evidence for now that exercise can lower some of these detrimental effect on the body of the anti-cancer treatment.
Okay. So if you exercise, it's less toxic effects. I assume that's if you're exercising during the treatment, like it doesn't help that you exercised previously.
So that's a little bit difficult to dissect because most of the people who exercise through their treatment also exercised before.
That's true. And they're less likely to take it up. Yeah.
Oh, yeah.
Okay.
So it's difficult to dissect.
Yeah. So it helps you. Yeah. I remember hearing that, what was it? That the chemotherapy is tolerated better in people that exercise. I mean, the one I read was talking about you'd have the chemotherapy and obviously you'd feel very unwell. And then during the gap to the next chemotherapy, the idea was to exercise and then you'd be able to tolerate. Is that right? Do you want to just take us through that a little bit? The tolerating the chemotherapy better? Is it the exercising during the gaps? Is it exercising the whole way? Do you know how that works?
Yeah,
because it must be hard,
absolutely.
right? It must be hard to exercise. A lot of people aren't going to feel like exercising during chemotherapy.
No. So chemotherapy has a lot of side effects like fatigue. It can even in itself produce muscle wasting. And many types of chemotherapy also induces insulin resistance. We know this from animal models, where they have been treated at comparable doses to those used in humans, because you will never just treat a human with this drug, right? But so we know that the chemotherapy can both induce fatigue in the patients, cause nausea, vomiting, and all of these things. But also can cause insulin resistance. And exercise has proven quite effective in lowering many of these side effects, especially the side effect of fatigue. Here, exercise even started like at diagnosis. So for those who didn't exercise beforehand, if you exercise through chemotherapy, the level of reported fatigue is reduced. And this is the strongest evidence for where exercise benefits, is really the level of fatigue.
Fatigue, okay.
But it also lowers some of the nausea side effects. And because exercise boosts the immune system, it can also help sort of lowering the time period after the treatment where the immune system is compromised as well. So these are all effects that are backed by evidence also in patients. Yeah, so I think that's important. And you can also assume that exercise, because exercise enhances insulin sensitivity.
Yes.
And if you have cancer and you then on top of that perhaps have some chemotherapy drugs, or maybe drugs that are used to lower the side effects of the chemotherapy treatment, then exercise is likely to be beneficial in restoring insulin sensitivity.
Right. All right. So I should point out that people, if they want to know more about exercise and insulin sensitivity, I had our great collaborator, I think he was your supervisor, Professor Eric Richter, on, so they can have a look at that. And we've also had Jan Wojciechowski on. So there's a lot of, if they want to get stuck into exercise and insulin sensitivity. But that's really bringing it together nicely, isn't it? Because we've talked about how cancer can reduce insulin sensitivity, and exercise has a whole bunch of important effects, but one of them is improving insulin sensitivity. So it's able to counter some of that. Can it kind of prevent it, or does it just kind of attenuate the reductions due to the cancer, do you know? Or does it depend how much exercise you do, I guess?
Yeah, I think we don't know in patients with cancer. We know that exercise can improve insulin sensitivity in people who have diabetes and insulin resistance, and also in people who have obesity and are insulin resistant. But it hasn't been tested in patients with cancer yet, whether the insulin resistance for people with cancer can be reversed by exercise. But really, if we stay a little bit with this remarkable effect of exercise on lowering or preventing insulin resistance or increasing insulin sensitivity, you could also say. I think it doesn't even rest with that, because that is an amazing effect, and that is an effect that was discovered by Professor Richter in Copenhagen, who I was very lucky to be supervised by, and he was also the one who got me into this field. So this is a remarkable effect of exercise that happens after the exercise bout. So it's quite amazing. So if you go for exercise, then in the hours after the exercise, the insulin sensitivity would be increased, even when you're back on your couch. And this could potentially have quite remarkable effects, I think, on people who have cancer or who are going through treatment that would induce insulin resistance. But there is also the thing about exercise that we talked about, these pores, that insulin is needed to get the pores to the plasma membrane so that glucose can come into the muscle and the fat cells. But another way of getting these pores to the membrane is by exercising. And exercise puts these pores in the membrane and increases the glucose uptake by the muscle independent of insulin. And this is so important, because that means that even in people who does not respond properly to insulin, exercise can still robustly get these pores to the membrane and take up the glucose. So I think this is very important if you think about an insulin-resistant individual with a tumor that wants to take up a lot of the glucose, and the peripheral tissue cannot take up a lot of glucose. Then if you go in with exercise, that would really suck in the glucose towards the working muscles. And that is independent of insulin, so therefore it works even in people who have insulin resistance.
Yes, so just to make sure people are clear on this. So yeah, exercise. So while you're actually doing the exercise, so while you're actually contracting the muscles will take up glucose independently of insulin. So you don't need insulin for that.
Yeah.
And then the beautiful thing, as you touched on, is that then when you finish exercise,
Mm.
and the other thing is, myself and others have shown that the glucose uptake into muscle during exercise in people with diabetes is actually normal if they do the same exercise bout.
Yeah.
So that can actually help with the glucose coming down during the exercise. But then, as you said, for 24 to 48 hours or so, it's not exactly clear, the muscle then remains more sensitive to insulin. So even though the exercise itself, you don't need insulin, you finish the exercise, then the next 24 to 48 hours, you'll be able to take up more glucose in response to the meal, for example, because you're more insulin sensitive. So it's just amazing. Now, I just wanted to,
and I think if I can just make the point that this is amazing, and it happens after every exercise bout. So this is something that also happens if you're not a trained person.
No.
So, and I think this is why every single exercise bout really matters, because even if you haven't trained for a month, you can go in and do one exercise bout or just being physically active. And then you have all of these amazing effects. I call them molecular miracles because they really are, that promotes this glucose uptake into the muscle during the exercise. But you also have this window of increased insulin sensitivity afterwards that can maybe last for days. So even if you're not a well-trained person, this is what you can
Absolutely.
you can sort of optimize the system for a couple of days if you do an exercise bout.
Well, I remember I talked to diabetes educators and things, and they would tend to think, I'd say, and medical doctors, like general practitioners, as we call them, they'd say, why do you think exercise is good for you? Oh, you lose weight and that makes you more, this and that. You say, yeah, but what about just one? So obviously, if we're talking about one bout of exercise, we're not going to lose weight. Now, this is this is not to do with losing weight is very important. Things you mentioned earlier with cancer as well, but they don't tend to think. So then the good thing is, I like to say is, people, just say a person with type 2 diabetes knows they should be exercising. But it's like, oh, but I haven't exercised for 2 weeks. It doesn't matter. Just do one bout now or tomorrow or whatever, and you will take up more glucose during the exercise and a couple of days afterwards. So I think that's good for people to know, that they can, every exercise bout, and as you say, you don't have to be an athlete. And we know that people with type 2 diabetes have pretty much normal glucose uptake during the exercise and pretty much normal increases in insulin sensitivity after the exercise. But because their insulin sensitivity is down, the change is similar, but they're still down. All right, great. All right, so so just with the chemotherapy again, are we talking about people exercising in between each bout of chemotherapy, or trying to actually do the exercise during the chemotherapy as well? That's what you're saying?
Oh, I think we're talking about people who have tried to do it throughout their chemotherapy cycles, but there are these cycles. They will also sort of be illustrated in different levels of energy for the patients throughout their treatment. So of course, exercise is only feasible to do when there is a window for the patients where the fatigue is not too overwhelming. So I think for patients with cancer, and I'm learning more and more about this now because we're also undertaking our own trials in patients with cancer. It's very difficult to set up an exercise regimen and then expect anyone who's going through cancer treatment or has cancer to follow it, because it is nearly impossible, because some days are going to be great. Sometimes, and maybe more days when you go through treatment, the fatigue is so overwhelming that the planned activity level you had wanted to do maybe is just not feasible to do. So most of these studies are just people trying to do as much exercise as they can throughout their treatment. And most studies have focused, and there's not that many studies still, and many of them are still just people who have reported to do exercise or to do physical activity during their treatment versus those who haven't. And they are, of course, biased in a way that the people who report that they can do physical activity during their treatment is probably also the ones who are not feeling as bad. Maybe they're not as sick. And then they have better outcomes. So we really need more randomized controlled trials where people under the same circumstances are randomized into an exercise and a non-exercise arm. The problem with that is that becomes a bit unethical now, because we know that exercise is
Yeah,
beneficial.
exactly.
So all patients should get exercise through their treatment. And this makes it a little experimentally difficult to dissect out the results, but it is beneficial that everybody who can exercise, they exercise. But it does make the interpretation of the data a little bit difficult, because it's likely that the people who exercise are also the ones with more energy. Maybe they're stronger to start with, and then they can exercise and
they end up doing better. Yep.
yeah.
So I guess we've sort of talked about physical activity and exercise, and I just want to say, can we just talk about that? Because physical activity sometimes is more like thinking about step counts and, just getting out and being active. When exercise, sometimes you might think it's more sort of structured, like trying to get your heart rate up or something. Do you want to just give us a bit of an idea? What sort of exercise are we talking about here? Is it trying to go for a walk, etc.? Has that been found to be beneficial, or is it more sort of structured, or what?
Yeah. I mean, first of all, I think it's important to mention that people who have cancer and are going through treatment, they're generally a little less physically active compared to those age-matched that do not get cancer. And this is, of course, likely due to fatigue. It could also be because physical activity levels is a risk factor for getting cancer. So more people who have led physically inactive lifestyle are likely to get the cancer. But if you put like these accelerometers on people, for example, there's a study with lung cancer where they have measured the physical activity levels, so step counts, and it can measure if you go up and down or move around in your kitchen. They do show that the activity levels of people with lung cancer compared to matched controls is about 20% lower in those who have lung cancer. Whether or not that directly translates into any effects on survival, for example, if you have a patient with lung cancer who then moves 20% less, is unclear. But we know in general that that you need to follow the recommended levels for physical activity. And this is done in about 40% or 30 to 40% of the older population, whereas this is adhered to in around 10 to 15% of people who had cancer. And these guidelines include half an hour exercise a day. And I think Kathryn Schmitz has probably talked a little more on this. But there are some, there are some studies that have looked specifically at whether it is the exercise volume, so the amount of time you spend exercising, that has a protective effect, or whether it has to do with the intensity levels, or whether you do higher intensity exercise. And so these have looked at a pretty hardcore endpoint, which is death. And they're sort of collection of a lot of data. For example, there is the Nurses' Health study that was following more than 100,000 women in the 80s, and then follow up. They're still following up, I think.
Wow.
And they looked at colorectal cancer. And then they looked at those who exercised more or less than 3 med hours per week. And they found that there was minor increases with, so I don't know if I should explain a med hour.
Yeah, I think you should. That'd be good.
I also don't quite understand it. So a med hour is a way of reporting physical activity. So it's self-reported from the people enrolled in this survey, and it's over a period of time. So for example, if we do walking, that's around 4 meds. So if you walk half an hour a day for a week, that would be 3.5 hours of walking, and then walking at this 4 meds, which is what walking is. That would be around 14 meds hour per week.
Okay.
Does that make sense?
Yeah, and if we just say
it's a way of combining what you do with for how long time you do it.
Yep. And also it's worth just saying that 1 met is sort of your basal. So just sitting here doing nothing. So if you say walking is 4 mets, it's about 4 times more energy per minute than doing nothing. Yeah.
Exactly. And then if you do that half an hour a day, that would be around 14 med hours per week. And some studies, and this study, the nurse study, showed that the big change or the big protection comes from doing more than 18 med hours per week.
18,
so a little
okay.
more than walking half an hour a day. But you can also obtain this by running, for example, or biking, for example. Like biking at a decent speed is about 8 meds. So double up of walking.
So half the time.
And get this, yeah, exactly. You'll have to spend half the time.
Yes. Okay.
Yeah. So here there is, so the big protection really comes if you do more than 18 med hours per week.
Yep.
And then in another study they did, which I think is a really cool study, because they actually dissected out the effect of duration together with the intensity levels. And this is one where they did, this is in patients with prostate cancer, so men. And they compared the effects of exercise volume on survival in those that exercised more or less than 7 hours a week.
Okay.
And if just looking at the hours, there was a 13% lower risk of death in those that exercised more than 7 hours a week. But they really showed that the intensity level mattered quite a lot.
Okay.
Because for those that exercised more than the 7 hours a week at a higher intensity, their risk of death was lowered by 66%.
Oh, wow. Okay.
This was quite a lot. So it's the same amount of time, but at a higher intensity. So I think the intensity based on these studies, at least for prostate cancer, is quite important. And there are other studies now coming out that also shows that intensity does matter.
And in terms of mechanisms, I guess we don't really know, because you said earlier, I was a bit surprised. I just want to make sure I got that right. You said we don't really know if exercise improves insulin sensitivity in cancer patients.
No, it hasn't been tested directly because insulin sensitivity is difficult to measure, as you know. You need to look at the sensitivity of insulin on the tissue level, and that still requires the quite invasive hyperinsulinemic use.
And it hasn't been done in animals like your studies or others? They haven't looked at that?
No, it hasn't been done in animals. We would like to do it, but we haven't.
I thought you'd done that.
We haven't done it yet.
I'll get on to it.
We're doing it right now in humans.
Okay, good.
We're doing an exercise training.
I thought you'd done that when I saw your mouse studies. Okay, cool.
No, I want to. We have stimulated with ICAR, which is some would call it an exercise mimetic. I wouldn't call it that, but it does activate some of the same signaling pathways that exercise activate.
So this is that AMPK people might want to look into.
Yeah, and I think AMPK is a key to maintaining insulin sensitivity in cancer, actually.
Yeah, so people again can look at Eric Richter's if they really want to. We had a big chat about AMPK and whether it plays a role in glucose uptake during exercise versus insulin and all that. So that's all interesting, but it gets a bit complicated.
It is very complicated, but I think that podcast would explain it very well. And the thing about patients with cancer cachexia is that they do actually have altered levels of AMPK, and we can also see some changes in the mice. So I think that could be a very important factor.
So seeing as we've sort of talked about it a bit, so AMPK is sort of like, we call it an energy gauge. So if the muscles, if you're contracting and you're using a lot of energy, the muscle tends to sort of turn on pathways, and it looks like AMP kinase might be involved, but yeah, it's a bit controversial and all that. Okay, so we're having a good old chat here. Now, have we covered a lot of fatigue? I guess we talked a bit about fatigue. So you're saying the exercise, so obviously you get fatigue. Now, does all cancers, people tend to get fatigue, right? Do you know, does the exercise improve fatigue pretty much in all cancers, or is it a bit early for that?
Yes, I think that's where there is the most evidence, actually, and across cancers, that exercise can really lower the cancer-related and also anti-cancer treatment-related fatigue for patients. This is some of the first evidence that came out, and it's only building stronger. So this seems to be across the board of the cancers that have been studied in this regard. Yeah.
You know, something Kathryn Schmitz mentioned, and I think I asked you about it in an email, I can't remember now, that the exercise can actually increase blood vessels in the tumor and therefore helps the chemotherapy to work because you get better delivery of the chemotherapy to the tumor and actually kills the tumor. Is that something that you're aware of? Because that, to me, that seemed remarkable.
I'm aware of the studies, and we know that exercise can can stimulate the formation of new blood vessels. And this occurs because exercise leads the blood vessels to produce nitric oxide that causes vasodilatation. But during exercise, this is mainly restricted to the working muscles. But we know that exercise also induces the release of different growth factors, such as the vascular endothelial growth factor that plays a role in angiogenesis. It promotes the endothelial cells to proliferate, and that can create new capillary networks also in the tumor. And this has been shown in animal models. I am not aware of any work done in humans on this. And this improved vascular network can enhance the delivery of oxygen. It can also enhance the delivery of nutrients to the tumor, because this is the way the nutrients gets to tissues, is via these capillaries.
Yeah, when she first said that,
what's that?
Yeah, sorry. When she first said that, I was like, wow, that's going to help the tumor. But you're saying the chemotherapy can get in there better as well.
Yeah. So it will just aid the delivery of compounds in the blood, right? Also chemotherapy. To my knowledge, there's no clear evidence that the chemo distribution to the tumor is increased in response to exercise, but it's also a little bit outside of my field of topic, so there might be some.
Well, clearly more work needs to be done. Now, the other one I thought about was metastasis. So cancer metastasis. Why am I saying that? Why does that sound wrong? Does exercise affect that?
Yes, it does, probably. I mean, metastasis is when some of the cancer cells from the primary tumor escapes and travels via the blood and then ends up in another tissue. So this is an explanation that the oncologist in my lab would not be proud of, but that's a very simple version of it. And we know that exercise can inhibit both the potential of the tumor to escape, or the tumor cells to escape the primary tumor, but also the ability of the tumor cells to survive in the circulation.
Wow, okay.
And also some of the mechanisms that are important for the tumors to reestablish itself.
Wow.
So one of the likely causes or one of the likely things that exercise does is that it really boosts the immune system. It increases the activity and number of natural killer cells, the T cells, and other immune components that can recognize and destroy cancer cells before they establish at a metastatic site. And this has been work that was pioneered by the late Pernille Højmand, who sadly passed away herself from cancer. But this has also now been followed up in human trials. And this could be a very important component to how exercise is protective against cancer metastasis.
Wow. That's incredible. Okay. So when we talk about exercise, improving the prognosis of people with cancer, it sounds like it's partly because you have less metastasis.
That is where the data points towards, and the basic research done in the field really shows that exercise has the potential to inhibit all of these sort of the three different components of metastasis.
Wow, that's incredible to me. That is because that's what often gets people, right? Is because
and I need to stress that, of course, these data are experimental still, so these are evidence we know from mouse and from cells, and whether or not this is direct effects in humans is so difficult to delineate, because humans are so complex, and we cannot say, oh, because this happened, then this happened. We cannot do that in humans. So a lot of these the evidence for why things are the way it is, for how exercise promotes its benefits, is really derived from more experimental settings where the systems are less complex. So I think that's important to say, but the evidence do point in that direction.
Yeah, so there's definitely a lot of things that are similar in humans and mice and rats, but there's a lot of things that are different as well. So you can't assume, but it's giving a good indication, and then you try and show it in humans, obviously.
Yeah.
Now, are there sex differences in well, obviously there's different cancers that males and females get, but is there sex differences in responses to exercise? And, with cancer and people with cancer, do you know?
I don't know. I think it also depends on what outcome you're after. I mean, we know that there are sex differences in insulin sensitivity, like in the average population. Women are more insulin sensitive than men. We also know that in just, healthy people, that the effects of training on muscle mass is a little more effective in men compared to women. And then with regards to cancer, we know that the development of cancer cachexia, so this loss of muscle mass, the emerging data now coming out from Teresa Simmers and others in the field shows that men seem to be more prone to developing cachexia compared to women.
Oh.
So this is things we know based on the evidence, also human evidence, but whether training is more effective in either men or women in mitigating the adverse effects of cancer on muscle mass or insulin sensitivity has not been tested. So we don't know this. But if I have to guess, with cachexia being more pronounced in men and insulin sensitivity generally being lower in men, I would guess that men would benefit the most from exercising. But it's a
More
guess.
studies for you to do here.
Evidence have to show, yeah.
Yes, you're going to be busy. I think we better wrap up. You've got a lot of studies you're going to have to go out and do.
Yeah, I
I'm
know.
just joking. No, it's great. There's lots of important questions. Actually, I was just wondering, with the men being more susceptible to cachexia, is that again, like, is it because they've got a bigger, I'm always thinking about relative versus absolute, is it because they tend to be heavier and more muscle to start with, so then they've got more to lose? Or do you know, is it per kilo? Is it say more kilos they lose, or is it more like percentage, do you know?
Well, it's more kilos they lose, but it's also relative to the start. Yeah. So they even if you take into account their muscle mass before the cancer, the decline is a bit more in men.
And I wonder if we know why that is. Well, I don't. When I say we,
I don't know either.
Not me.
No.
Yeah. Okay. Now, what about the effect of age? So I think you touched on it earlier. Is it the older you are? I guess you tend to be more frail and it might be a bit harder to exercise. But do you know, is it if as long as you're able to exercise, do you still get the same benefits as when you're older? Do you know?
Yeah, I think there hasn't been a lot of good controlled studies looking at this, but it does look like younger patients who get cancer, who also get cachexia-inducing cancers, they do seem to tolerate treatment better in general, whereas in the elderly, probably because the baseline set point is shifted down a little bit, they may have sarcopenia already just due to age. Then a smaller reduction in muscle mass may place them at high risk of frailty or higher risk of treatment
closer to that.
And this is also where the data is pointing that young people, even young people who get cachexia from their cancer, they have a higher or a lower treatment toxicity. But the degree of cachexia seems to be the same. So if you get a cachexia-inducing cancer at like 40 years of age, God forbid anyone, or at 80 years of age, the cachexia seems to be induced the same. But the set point, of course, will likely be higher, younger, more well-trained individual.
So again, if you've done exercise and you've got more muscle, especially as you get older, if you maintain your muscle mass.
Yes,
I always think,
everything points towards that as a benefit for survival, for treatment toxicity, for the fatigue. quality of life. Absolutely, yeah.
Yeah, I always think about, I had Michael Joyner on a couple of times, so people can have a look at that as well. And he said he wants to, saying it's really hard to maintain muscle mass when you get to 70. So he wants to get as much muscle as he can. By the time he gets to 70 to try and maintain it. And I was thinking about, getting out of a chair and just, quality of life, but not necessarily thinking about cancer. But again, we're a integrative, life is an integrative thing. So it makes sense, I guess, that if you've got more muscle and you're more fit and everything, it's going to help you in many ways. Yeah.
Yes.
All right. Now, we're saying how good exercise is, and then it makes me think about this question. So we asked for questions on, well, we don't call it Twitter anymore, on X. And Adam said, I'm trying to persuade a major gym chain in the UK to offer free membership whilst people are undergoing cancer treatment. That's an interesting concept. I'm not suggesting you would have an answer to that, but that's interesting, isn't it? And
yeah, that would be great. That's a great idea.
Yeah. And I think I mentioned something that to you earlier on. I think you said there's a bit of a movement in Copenhagen or something towards, what was it? We were talking about something before you came on.
I think we talked a little bit about this question actually of why, I mean, with this amount of evidence, why doesn't every hospital, provide training for patients?
Yes. And you said
I,
it's getting better.
I think it is. I know in Copenhagen this is being implemented. I know there are also some barriers, of course, but I'm actually quite optimistic about this. I think that it's being more and more implemented in oncological departments around the world. We can also see it with Kathryn Schmitz you had online, that this whole moving through cancer project in the States. So I do think it's coming. I think membership to the gym would be fantastic, free, it should be, but also sort of having the capacity to train patients at the hospitals, but also to do some home-based training would really, I think, improve the quality of the treatment that can be provided to patients. And I think it's, of course, going too slow. We would have wanted this for everybody yesterday, but it is difficult to implement. It takes a lot of resources. It's a lot of people who needs to be educated about this as well. And you need, to make the space. But I think it's coming. I'm very optimistic. And I think also, I mean, now that the treatments or the standard of care includes nutritional support. And the way I see the evidence, the documented evidence for beneficial effects for exercise versus nutritional support is much better and much stronger for exercise's effect. So I do think it's about time that the treatment of the patients are updated to reflect that we're following the evidence as well. But I'm quite positive that it will come. Also, with the more evidence, we can show more evidence, for example, for that exercise can reverse cachexia. I think this still needs to be shown in different trials. And there are some trials coming out. Then there's one in Norway, led by Thor Sondheim, where they're doing this multimodal treatment to see if they can prevent the development of cachexia for patients. And the data was just shown in an abstract this year at a conference, and I think the data looks very promising. And I think these are the kinds of data we need to inform the oncologists, inform the caretakers that this is something that would be beneficial for the patients.
Yes, indeed. Now, I actually realize now what we were talking about beforehand, because Vincent sent a message on X saying, given the extensive data on the benefits of exercise for cancer patients, why do you think there aren't systematic exercise programs implemented in hospitals? And that's what you were saying. You think it's becoming more and more.
I think they're coming.
And recognizing it. Now, the other thing you said was that the diet, because, for many, many years, there's often people saying, thinking a lot about the diet of the person that's got cancer, but you're saying the evidence is much stronger, or stronger anyway, for the beneficial effects of exercise than changes in diet or particular diets, for example. Yep. Okay. All right. So
that's the way I see the evidence. Yeah, absolutely. But I think it's not one or the other. I think it needs to be multimodal. So So sort of
Yes,
acting in synergy together. And I think this is where exercise can really potentiate the benefit of nutritional support, because nutritional support is good, but it will end up, so our food intake ends up in fat if we do not move. So
exactly.
what exercise can do is to make sure that these nutrients are really funneled into a buildup of muscle mass. And I think these synergies between the two interventions are super important, and needs to be utilized much more in the clinic.
Okay, so just again, the muscle. So we think about muscle. So with exercise, you feel like if anything you want to be, if you're going to do one thing, because you know how the guidelines, you'll say we want people to be doing sort of aerobic type exercise and strength. You would say if you were not feeling well enough, or if you didn't have the time, would you if you're going to go one way or the other, would you say trying to maintain the muscle mass with some sort of strength would be more important? So
I think it depends on the problems that each individual patient faces in response to the cancer. I mean, some cancers where there's not an associated loss of muscle mass, I probably wouldn't worry too much about that. I would worry a little
yeah,
more about
true,
bumping up my metabolism.
true.
We worry more
Mm.
about insulin resistance, whereas in the very cachexia-inducing cancer types, I would focus on building up muscle with resistance exercise training. But that said, there are no studies that have tested if one training regimen versus the other is more beneficial
Wow.
for some patients than others. So there are really not these personalized guidelines yet. I hope they will come, of course, but
Yeah, so it's really sort of we're behind the times because obviously cardiovascular disease and cancer are huge killers, and there's been so much more done on, you know, the benefits of exercise on the cardiovascular system, etc. But cancer's just sort of catching up. Yeah, there's a lot more to be done.
yeah.
All right. How about we do some takeaway messages? So exercise and cancer. So if you want to wrap it up here with some takeaway sort of messages you want people to get from our chat.
Yeah, I think it's well, I think the first thing is that there's quite clear evidence now that exercise lowers the risk of getting cancer in the first place. And then once a person unfortunately gets cancer, exercise also lowers the, the side effects of having cancer. And for some cancer, there's also evidence that exercise lowers the risk of death from the cancer. And then I think from my perspective in the line of work I do, where we're less focused on the cancer as such, but focused on the effects of the cancer on the body, I think there are really two things that could be important and also could be important for the survival of people and why exercise has benefits. And the first one is how exercise really can help improve the metabolic control that can otherwise be dysregulated in response to the cancer, but also that exercise can really help facilitate that not too much muscle mass is lost during the cancer and the cancer treatment, that can protect the patients from treatment toxicities and help also in the longer run getting people healthier through their cancer diagnosis. I
Right.
think these are probably the most important
Yes.
things. And I hope that one day we can explain this a little more biologically, how these effects occur.
I wonder if I can remember how we talked earlier. That's great. But just before I let you go, how we talked about, you know, and there's a bit of a conjecture that maybe, you know, the tumor takes up a lot of glucose and makes the
Mm.
body, maybe making the body insulin resistant. So that it actually, the body uses less glucose and the tumor gets more. I wonder if exercise is fighting all that because it's making the body more insulin sensitive. So therefore the body will be taking more glucose and there'll be less for the tumor. But also by doing exercise and trying to maintain your muscle mass, you're stimulating muscle production maybe and having less of the muscle broken down and going to the liver and producing glucose. So in that way, both the exercise in both ways, and I'm sure there's more than just those two ways, but the main ones we talked about, are making the tumor unhappy, having less access to glucose.
Yeah, I mean, I think the way this happens in the body of a human is a bit unclear, but we know for a fact that if you grow tumors in high glucose medium, they grow faster. If you grow them in high insulin conditions, they grow faster, if you do this in the lab. Whether this is then the case or not in patients, I think is still something we need to prove, but we know that exercise results in better glycemic control, so better control of the blood glucose, and also lowers the insulin levels. So I think it would be a very logical biological explanation for why exercise protects against cancer and why exercise can protect during the cancer prognosis.
Right. All right. And we know that exercise is good for you no matter what. So even if we don't know the mechanisms, which is really interesting, we know that as you said right from the start, the evidence, the epidemiological evidence is that exercise reduces your likelihood of getting cancer, improves your prognosis during the cancer. And I think you said it reduces the likelihood of getting it again as well. Yeah.
Yes, exactly. So for people who have had cancer, they actually had increased risk of getting cancer again. So there is a high rate of cancer recurrence. And for some cancers, exercise, for example, breast cancer, that is the most common cancer in females, excuse me, exercise has been shown to lower the recurrence rates of breast cancer.
Fantastic. All right, so let's all do it. So whether you even if you don't ever get cancer, which hopefully is the case, it's going to improve your cardiovascular function and all these other things, reduce your anxiety and things, but also reduce your chance of getting cancer, etc. So thank you very much again for coming on. It's been great to chat, and enjoy your holiday. You'll be heading west to Jutland or Jutland to us non-Danish speakers.
Yeah,
Okay.
I'm going to the top of Denmark.
Yeah. Okay, good on you. Thanks again for coming on.
Thank you, Glenn, for having me. Thanks.
Thanks. See you. Bye-bye. I hope you enjoyed this podcast. And please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.